I feel like I'm the Grimmy because I have to tell people about these deaths that I see, and I'm an IT person. I've seen way too many people die in an operating room because that's, my history is from a device failure or from something because of a device, and they don't get reported because it's so time consuming. And the regulation is voluntary only if in the event of death or severe injury.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On this episode of Power Supply, we're going to be speaking with Joan Melendez, president at Xcelrate UDI. And Hayes, it's going to be a very good conversation. We've talked about UDI in the past on Power Supply, and we're going to be talking about it again. There are so many different applications for this technology and what the implications might be. We're going to focus on two areas of conversation today. One is instructions for use, and then another one is going to be on adverse event reporting. And so out there in supply chain, you may not know exactly what does this have to do with me, but it's got some implications for you regarding contracting and your value analysis processes. So stay tuned, because we're going to have a great conversation with Joan today, Hayes.
Absolutely. I learned a ton, but to your point, we've come so far in the last 15, 20 years in this whole category. 2022 is a big, big time. Stay tuned. You're going to learn a lot, and you might even hear a reference to the Jetsons. So come on and listen.
All right. We're going to be right back with Joan. Stay with us.
Boom! I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
Speaking now with Joan Melendez, president at Xcelrate UDI. And Joan, we've had a few conversations. We even had a UDI expert on the Power Supply channel in the past. And so I do think that the audience, especially if they're heavily engaged in supply chain, which this one certainly is very familiar with UDI. But I know that we're going to be talking about some applications of UDI that may not be ones that folks are familiar with, really the true potential. So I want to thank you so much for coming on the show and appreciate you putting up with the three of us today.
I'm really excited to be here. Thank you guys so much for taking the time to have this conversation.
I can already tell I'm going to like Joan because before we started recording, she put up with us really well. And I can already tell her, not only is she very competent, other than coming on the show with us, but she clearly, I'm looking forward to hearing what you have to say.
Thank you.
Joan, why don't you just tell everybody about your background and why are you so excited about the potential or unlocking the potential of UDI?
Yeah, it's been a great journey. It started back in 2013 where, the adoption of UDI was really just at its infancy. Supply chain really didn't adopt it fully until 2022 when the Class 1 medical devices came into effect. So back when it started, I started getting really excited, started working with manufacturers, the FDA, even international governing bodies in order to really ensure that the potential of the UDI as I saw it was just really optimized, and everything in the EDI transactions, just everything from the minute we are thinking about ordering that device to attaching it to the IFU, making sure we have an IFU. And the UDI really does play a pivotal role in that. So I'm excited about the conversation.
It's interesting because when you and I met, I had told you that when I very first became a sales rep and left nursing way back in 2010, I had sort of become aware of UDI, and then I attended the statewide ARM conference in Pennsylvania in State College and had seen a speaker there, Karen Conway, talking about UDI. And I said, I'm supporting sterile processing primarily in my role, and I can see where there could be a huge potential here for disseminating accurate instructions for use, because right now it's in the form of paper. It's being logged in a book. What if there's an update? And wound up doing an article in Healthcare Purchasing News with Karen and Karen Netto back then. But the reality of that seemed so far away. And yet when you and I talked, you were like, well, your idea has now become a reality.
I felt it in the
air. So why don't we talk about your involvement and experience with UDI? Because you don't just live and breathe this necessarily with the work that you do, but you're also very much involved in a lot of the organizations that are helping champion the positive impact that this can have and getting standards adoption.
3 big organizations or, bodies that I'm involved with is the FDA. I stay very heavily involved with the FDA. I attend their meetings. They just recently had last week a meeting about the 506J device list, which is the devices that are, on shortage or have manufacturing concerns. So it was really great to be involved in that because we have to look at the UDI, that medical device, from the time that it's a concept, and really just starting to go and get deployed. And in order to really identify that, not only with the FDA, but I sit on several work groups like ARM, which I'm sure everybody's familiar with. They have what's called the Learning UDI community, and I encourage everyone to get involved with that. And that's where we come together, manufacturers, providers, and now, thankfully, some EHRs are starting to get involved, but I was like the only one on the technology side. At least I felt I was the only one who was really voicing an opinion, because when I look at the UDI, I look at how that can trace that device from, again, manufacturing till it's used. And I got it started because of the implantable device list. That's how I originally got started.
Joan, I just want to take it back one quick step. You're talking about implantable devices, and we have a wide range of listeners.
Right.
What type
everything. Everything. I'm talking about everything. So even equipment, they everything. Band-Aids have to have a UDI now. And that all went in final regulation in September of 22. So everybody should really start using that and tracking on it. And even gloves, when we had COVID, we were getting this influx of gloves. And then all of a sudden we have ones that went on the FDA's unauthorized list. They don't meet the guidelines. They're not, there's something wrong. There were recalls. There were a lot going on, even just with gloves. How can we as supply chain and the end users, how can we quickly identify that device? By scanning that barcode, which is the UDI on the package.
I so appreciate that clarification. My mind was going directly in the OR. I was thinking about pacers. I was thinking about implantables. Yeah, I was thinking, yes, so thank you.
Implantable are my passion because we're failing the patients. Because if we look at, even the CPAP machines, with those recalls, that was a failure. Could you imagine if we would have been tracking those devices by UDI? The UDI marries the serial number or the lot number with that unique device identifier, with that catalog or reference number. So you can really isolate exactly that product. We had one where a stapler was misfiring in the operating room, but it was misfiring, so we were able to isolate it, send one back to the manufacturer because there were 10 in circulation, pull them all, send one back, It ended up being a global recall because there was a misalignment that we were able to trace because of that UDI, that unique device identifier, because it told us exactly what, or it told the manufacturer exactly what location it was manufactured in.
Well, Joan, this brings up a couple of questions that I have. And first of all, I've been listening to GSI and all these terms for 20 years now in my supply chain group. And so this is exciting because it sounds like we've made a lot of progress. But where are we on the timeline, right? I mean, 20 years ago, we were just, hey, it's a concept. It's something out there. But it sounds like we've made a ton of progress. And where are we now?
We have made a ton of progress. Again, all classifications of medical devices are required to have a UDI. So the identification is there. Now, working in these work groups like LUC, we're actually pulling them in to the EDI transactions. We're allowed, there's now a field for that UDI so that that device can be properly identified. So, it's up to companies like mine where we really look at that device and how can we then translate that device into actionable workflows at every spot, because we just don't need the IFU, when we're in reprocessing. We need that IFU when we receive it because there are temperature limitations. There are storage limitations. I was working with a hospital that didn't realize that the particular Bovie they were using had 20 reprocessing limits because they were following a different Bovie reprocessing guideline.
And here's the other thing. People don't even realize that there may not even be a technology to track against those limits. It's all willy-nilly, in terms of the actual technology that would be in place for you to even know, especially if you're not leveraging UDI. Right. And you made a really great point. UDI, at least right now, is specific to the lot number, not the serial number. So you'd still have. Oh, it does pull in the serial now. That's great.
Yeah, so let me explain the UDI. So it's made of two components, the UDI DI, which is the device identifier, and the UDI PI, which are the product identifiers. And the product identifiers are the manufacturing date, the expiration date, the serial number, the lot number, and the manufacturers are putting other codes in there, like 240, which is something that they can use to identify. But because the barcode is on the package, why are we not ahead of where we are? That's why I created the application that we have, because we're still so far behind in technology when we have this great information now, and now we have the good ID. So in order for a medical device to technically be sold on the market in the US, they not only have to have that UDI, but they have to be registered with a good ID.
All right. I want to pull up a couple of things that really tee up application, because I want to, the application of UDI is so broad. We could probably talk for half a day just on all the different ways to leverage this, but I want to tie it to a couple of reports from ECRI or ECRI, and they just came out with their top 10 health technology hazards for 2024. They do this every year. There is almost always something on here related to reprocessing. As somebody who supported sterile processing, for a good bulk of my early career, there was always something on this report that related specifically, to sterile processing. And, that's kind of why I was keyed in on the instructions for use. So for this year, number 2 on their list is inadequate or onerous device cleaning instructions endangering patients. So that's a big one. And that ties directly to what we were talking about, when you and I first connected. So, despite some advancements, that's been a known issue for sterile processing leaders for a very, very long time. And now here it is heading the list. I want to tie it to one more because last year in 2023 in their top 10 hazards, it was underreporting of medical device failures was identified. So these two things are actually a lot more related than you might think. I think one impacts sterile processing heavily in terms of, usability, and the application of UDI. And then the second one really hits home in the operating room. So we're really targeting surgical services in this conversation. I actually want to pivot to the underreporting of medical device failures. I did have an interview. We did an episode on our sister podcast, First Case, with Dr. Larry Muscarella, and he was talking a lot about MOD reports and how that data is structured and how difficult it is to get facilities to report on, the errors that are happening, in the hospital. And so the first question I asked you, which I'm going to ask you again here, is I didn't think that there was a responsibility necessarily to report. I knew the manufacturers had one, but I didn't think the hospitals had one. Can you demystify this for us? What are the responsibilities of all parties involved?
Oh my gosh. So demystification. Yeah, unfortunately, medical device reporting is voluntary. People need to understand that. Even though it's voluntary, we should still be reporting. It should be mandatory, in my opinion. When I look at MOD, I see a tool that they have. It's the MDR. So the MDR report feeds into the MOD. It's all unstructured data. So meaning it's just free text fields. They did, though, I don't know if you guys have noticed, they added one field so that you can select a device failure type. But that was after, there was, I kept on asking them, they had just free text. How can you do a report based on free text? How can you isolate? Is it a device problem? Is it, a failure? What exactly is it? So by using a codified list, you can select it. But yes, it's voluntary and it's a nightmare to complete. That's why with our app, it doesn't matter what the, user is using. They just select the device and we have a codifiable form that they complete. Very few free text and it pulls in all the data about that device. That's what's needed. The FDA makes it too hard. If that MDR had like the good ID attached to it where you can actually select the device, because again, remember I said that the UDI is required to be registered in the good ID. So they could select that device and then it would pull in all the information. Right now, every single field is free text.
So that data is super usable.
Just loads of fun. Yeah.
I mean, I think honestly, I would think, and this has always been sort of something that I've kind of talked about, but I don't know if it's actually done. But we have all of these value analysis committees, new product adoption. And I would think that, looking at medical device reports on the FDA website would be a big part of the due diligence that facilities would do. Do you find that that's the case or not?
It's not my job. So that's kind of mean. But, it's one of those things that, we're all overwhelmed. There's so many things that we have to do. And I really think going back, I'm kind of, a senior as a couple of you guys are. So I've been in the healthcare field for a long time. So, I look back at when I first started working in supply chain, OR, central sterile, that was back in 2005. So, and the nurse that I was working with refused to work with me as an application developer for their ERP system, their item master, until I learned every single aspect of that product coming from the minute we ordered it all the way through. So, yeah, there's a lot of challenges.
Well, I was just going to jump in there and take up for Justin and Gary about you calling them seniors.
I was just going to say, I want us ranked in order. That was actually my follow up. I'm pretty sure I'm older than Gary. I'm not.
Dude, I'm embracing it. Not a chance. I'll embrace it all day long. Bring it, Joan. Love it.
And I'm going to be 62 next week.
Oh my gosh.
Well, I've been coloring my hair gray for years, so I'm just going to let it go natural. I'm getting. Justin's been coloring his hair too, I think.
Color, it's gone. I have no hair. I took it off once it was starting to disappear and go gray. Forget it. Own it.
Oh my gosh.
We digress.
Yeah.
So Joan, I mean, you're extremely smart on this UDI and the good ID and the DI and the PI. I mean, I've learned a ton already. But what are the biggest struggles right now? You mentioned 2022 was kind of the banner year where we got things moving in the right direction. A lot of good things, Justin, you discussed earlier. but what are our opportunities right now? What do we need to be focusing on? You're seeing it at the level in DC. You're seeing it at the national level. Would love to hear your perspective on that as well.
Yeah. Last week when I went to that FDA meeting, nobody really knew what the UDI was. So
level set, right? Create a baseline. Current state. Where are we at?
I'm so excited because we have every medical device manufacturer has that UDI on the package. And sometimes it's on the device itself. Some gloves have it, but yeah, it's education and getting people excited about what it can do. I feel like I'm the Grimmy because I have to tell people about these deaths that I see, and I'm an IT person. I've seen way too many people die in an operating room because that's, my history is from a device failure or from something because of a device, and they don't get reported because it's so time consuming, and the regulation is voluntary only if in the event of death or severe injury.
Joan, you went right there where I always bring it up. It's the mission. What is the ultimate responsibility and your passion and your mission while you're doing it? It's for the patient.
Patient. I did a diagram and sent it out on LinkedIn, and it's that patient in the center. We have to do better. We identify our cars. I think we had talked about not Corvettes earlier, but Camaros. So we do a better job of identifying that car, the VIN number, and we know exactly what we can and cannot use with it or on it. Why aren't we doing the same thing with medical devices?
You're right. We don't have a Carfax for medical devices. That's crazy.
Oh my gosh, Justin, well said.
All right, that's the next thing. All right, let me ask you this. We all remember, probably as you were kids watching the cartoon, The Jetsons. You remember how great The Jetsons was? They literally had not only,
Rosie.
Yeah, it was just so, yes, exactly. But you've been able to have video conference calls, all that thing. That was 30, 40 years ago, whatever it was. Where are we now in the next 10 years with this? Are we talking about the Apple Vision Pro or whatever they call that thing and using it in the OR? What would be ideal?
Oh my God, that would be, can you imagine walking into your supply chain area and have a pair of goggles on and just, because we scan, right? We're scanning that UDI, that barcode, but you can walk in with a set of goggles. As long as you're able to take a picture, you can just sweep that entire area in seconds to see if there's anything that's recalled. Patient safety, because when we look at recalls, the FDA doesn't update their database usually from the time a manufacturer initiates a recall to the time it's posted on the FDA site is average 69 days. How many patients are getting injured between that time?
Well, 69 days to get updated, but you basically just told us nobody's using the data that's going in there anyway. So unless you force a recall, and even then, what's the actual time to effectively recall all those devices? I mean, there's obviously a big lag there. That's a really important distinction. I mean, I realize that Jetsons, sort of picture that we're painting is close, with Google Glass and things like VR and assisted or augmented reality. These are things that we're going to see more and more, but we still have to be able to yeah, we could document better.
So we can we can look at, if it's an implant, or if somebody has a machine at home, all they have to do is really look at it, that's why that barcode to me and the UDI is so exciting because it's such a transactional 14-digit if it's a GS1.
But it's that whole database piece too, right? It's cleaning up that data. And even if facilities aren't necessarily required to report, you still have to weed through the information that's been reported to even know if it's valid, right? Sometimes it's it's a user error, correct?
Yeah, but when we're looking at MAUD, we're able to at least look at that kind of data. But the sad thing is because most of these devices aren't returned to the manufacturer because they're considered biohazard because they've touched a patient. They are not able to evaluate it, so they blame it on the user. When in fact it's more likely to being a manufacturer defect. I mean, I don't know if you've seen the news with the Da Vinci recently and that woman who sadly passed. But if you look just at Maud, which only, by the way, returns 500 items for your search. So there is limitations. And again, that's why we extract all their data. We make some sense of it. But when you look at that one device, 260 adverse events reported monthly. Why?
Even if it is user error, then there's a training issue that you've got to address, right? And
right. They're required to go through training. You know, the manufacturer, well, let me back up. The FDA thinks that they're being required to go through training, and they're not, because no one can make them do it. Just like accessing the IFU, you know. But thank God now the Joint Commission and these other agencies are stepping up and requiring the end users and the user facilities to have, you know, the instructions for use. But then that has its own challenges.
But Joan, are there any penalties if they don't?
There's this new thing called the Information Blocking Act. So, and anybody can generate an Information Blocking Act claim. It's through the government, but it's rare that anybody's penalized. But with the new information blocking, it could be anybody. It could be a surgeon. It could be an EHR. It doesn't matter. A patient or a person can report through information blocking that they're not able to get the information that they've requested on a device, that, you know, they feel they're harmed, and they are actioning those, and they're actioning them. They're about $1 million just per penalty. And then it's starting at $1 million, but that's the only way that anybody's going to take accountability, fortunately.
Yeah, that's what I was thinking.
Kind of a tough pickle to be in as a healthcare organization, right? You don't necessarily have the technology in place to actuate, you know, what needs to be done to do that well. There aren't a lot of dollars available to then invest into that kind of a technology. And yet on the other end of it, it's now actionable that if you don't put in those processes, that you could get hit for up to $1 million each occurrence. So, I mean, it's quite a pinch. I'm thinking, you know, this a lot of this conversation is really directed, I would think, towards the value analysis professionals out there. Cause I was kind of thinking to myself, you know, how do we get clinician engagement, but also what is supply chain's role? And then I think about it from the standpoint of the best place to address new processes and make sure that you have what you need is when you're doing new product evaluation to say, hey, we know we need this, but traditionally we have not had the technology available to maybe track those limits. Like you said, the reprocessing limits. We traditionally have not been able to do this. So before we can bring in anything new, because that's an unknown to the organization, before we can bring in anything new, we need to evaluate, do we have the ability to follow some of this? And I want to hear more recommendations from you, Joan, about how to connect maybe that supplier and supply chain and clinician around this in terms of best practices. But I got to think involving it in value analysis for new product adoption is like a great place for everybody to start.
Exactly. That's, you know, that's where everything should start. And if we didn't evaluate that product, guess what we should be doing? We should be evaluating that product. We should evaluate everything we have on our shelves because, you know, some systems are wanting us to, let's go with this one manufacturer. We can get everything cheaper. But, you know, that might not necessarily work because like in the case of that stapler I was talking about earlier, they just had a faulty line that they actually ended up removing, but we were forced to use theirs over a different one. So, you know, what are we doing, you know, with the communication? You know, with the VAR, I really look at VAR, again, doing it repeated times. You always want to check for recalls. You always want to check for adverse events. And, you know, and supply chain people are sometimes the last to know about an adverse event or a recall, because when manufacturers send these things out, they send them out to the head of supply chain, where it sits on the desk, or the head of the OR, they just not to the person who needs it. And then we have these great solutions like Xcelrate, but again, when you're looking at Xcelrate and other recall databases, it's a database. So they are reliant on the hospitals to report, hey, I just got that recall. Did you guys, and I don't see it on your database. So that's how Xcelrate is getting notified. It's not coming from the manufacturer.
Joan, you're making me think of a negotiation strategy on an agreement. As we move forward on KPIs, we move forward on QBRs, call them what you want, MBRs, whatever the spend is. But why couldn't we ask an agreement with the vendor or the manufacturer, whoever the agreement's with, is to put it in there, a notification of those proactively as they come up in a timely manner and hold them accountable per the agreement moving forward? I don't see why we couldn't look at that as an opportunity. What's your thoughts?
Before we go live with any of our clients, we have them renegotiate their contracts with their manufacturers because we want to make them stronger. We have them add in we have to have your UDI. It's regulated. It's required. We have to
UDI,
and you can't dump products on us that are expired within 10 years in some cases. We look at the shelf life of that device to see what its outer limit is, and we don't want to receive anything into our warehouse, into our hospital, that's going to be expiring, especially within a year. The only thing that ever should be accepted in is tissue, because there are that
absolutely
long expiration dates on everything else. I really look at the good ID. I hope people after this will, go out to the FDA's good ID and look at it. It has amazing information, again, using the UDI, but you can search by the catalog number to get the UDI. But it has MRI safety. It has GMDN information. So that's the description that ties all these devices together. I tried to go to the FDA last week and ask them to include the UDI on the 506J device list because I think it's such a critical component because we need to know when these things are out of our control and we can't get a hold of them.
I will say, Joan, that this is taking me down a inventory management agreements where we want to put on the shelf what goes on the shelf versus a UDI, what's utilization. You kind of just gave me the blow your mind concept that is probably the next podcast for like 45 minutes with Hayes and Jess and I's boots on the ground to really talk about what needs to go there. I'm thinking about new cath labs. I'm thinking about all the way to Band-Aids. I mean, you took me back to Band-Aids all the way to drug-eluting stents in my brain. And so I'm thinking about all the things based on utilization. I'm going to pause and stop because you're taking me down a road of agreements in my brain that you blow my mind with that last comment. So thank you. That's where I was going.
Agreements are the way to go. You want to include, and why not? The other thing we have them do is we have them include that they have to communicate with us about the IFU. We will not pull it in. And within our application, what we've done, and others can do this too, is if they go to scan that barcode, and if the hospital didn't authorize it, it pops up a warning saying this is an unauthorized device. And so that's the other thing we added to contracts. That's the last thing I'll say on it, is that if you bring in a product that is unauthorized, you will not be paid. So we have that written into the contract. So the contracts are super powerful to make sure that we get the UDI and the IFU, to make sure that we're providing safe patient care. Again, that patient in the center for us is super important.
Yeah, you could really tie it to that bill-only PO. And, I think another thing that is, kind of important too to note is that manufacturers are required to do a recall notice. It's just often going by paper and not necessarily reaching its intended audience. And the whole process for that can be a real struggle for hospitals. And I'll add one other element to the contracting piece. And we may have said this on a prior episode. I'm not sure, but I've always felt like contract templating nowadays, with just the pace of play on the technology and the data management, hospitals are already catching on to saying, no, we own the data. If it's about our patient and it's about our facility, we own that data. You don't own that data. But what they're not necessarily saying is we also expect you to have some reasonable level of data integration with the other platforms that we utilize. Because, we're often struggling to find a central reference number that's global that can allow us to be interoperable. This is one of the most advanced. I mean, even tax ID, when it comes down to managing companies, is not necessarily going to give you a one-to-one relationship with who you're doing business with due to distributors and everything else. It doesn't always navigate you back to the manufacturer the way you might like it. But when you go to the device level and you use UDI, this global identifier has major positive implications for interoperability. And so I feel like a lot of hospitals and health systems should get ahead of it in terms of detailing the usage of that information interoperably throughout their organization. I think would be critical. Anything else you can think of? I know we're out of time, but to be forward thinking about what may come and what the positive implications are of UDI, that similar to sort of like how they're setting up their contracts, that facilities and especially like contracts managers on here should be thinking about, like updating their templates to set themselves up for success versus having to go back and maybe like do addendums to all these different agreements to make what their next initiative work.
Yeah. Get excited about what's to come, right? ISO 13485 was adopted by the FDA. That makes me so happy. And that is just going to strengthen medical device regulations. So the manufacturers now have, there's stronger requirements because of that ISO. You said something about manufacturers are mandatory reporting for recalls. It's actually still voluntary from the manufacturer side. So,
what? Seriously? Is it?
Yeah.
I thought they were required. You've got to be kidding me. I just thought it was an antiquated methodology.
No, I know. No, there was a recent shoulder recall based on a hip, a knee, and several other ankle that have all been recalled by this manufacturer. And the FDA said that they needed to recall the shoulder as well, and the manufacturer said no. So, but with that said, we need to all get engaged. That's what I want people to come away with. Look at that ISO 13485. It's a game changer in using that with the UDI. We need to really look at any medical device. Again, it doesn't matter if it's a glove or it's a heart pump. Every device has to have a UDI, and we need to really be able to look at those instructions for use, from ordering till the patient sometimes even has a UDI. So I just really want people to get more involved, join the Learning UDI community from ARM if you're in healthcare. And then I am here. I love to talk UDI and IFU. So I'm your girl. Give me a call.
Well, you're talking all about it on LinkedIn. I mean, you're really putting out a lot of content on a regular basis. So I want to commend you. As you mentioned, it's so much about education, and you're clearly committing to it by putting out articles and information on social media. And we're obviously big on social media, all new media of all types. So you did a great job on the interview today, Joan. And I just want to thank you so much for coming on.
Oh, you guys, thank you so much. It's been an honor. Thank you so much for having me.
All right, that was Joan Melendez, president at Xcelrate UDI. And Gary, great conversation today about the potential applications and usage of UDI and how that can be, or what implications that might have for your value analysis processes, as well as some of your contracting templates out there.
Yeah, Justin, it's a key tool that I think we need in our hospitals. She comes with a wealth of information. I think we could listen to her for about 3 hours of just dialogue on good IDs and IFUs and DIs and PIs, but her knowledge based on just having that indicator that really talks about the device, whether, to her point, it's a Band-Aid or a drug-eluting stent. Across the board, these UDIs have so much great information to support our hospitals, and ultimately what she said in her mission, our patients. So great interview by Joan.
Yeah. Great potential for interoperability as we try to cut out the humans that have to translate and make data usable in hospitals. So great job today, Joan. On behalf of Hayes, Gary, and myself, thanks for listening to this episode of Power Supply.
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.